Welcome to Webisode 1 on Safe Inductions. I am Eric Morse, an addiction psychiatrist who has over 18 years experience working in opioid treatment programs. According to the federal regulations, which can be found in 42 CFR 8.12 and explained in more detail in tips 43 and 63, getting patients started on methadone or buprenorphine in an OTP requires a documented physical exam, documentation of meeting criteria of opioid use disorder for more than 1 year, and a face-to-face evaluation by a physician or advanced practice provider exempted by the North Carolina State Opioid Treatment Authority, also known as SOTA, and the Centers of Substance Abuse and Treatment prior to determining the first dose. We consider the induction period to be the first few weeks of treatment. We want to help patients get on a stable dose that does three things. Number one, covers the majority of opioid withdrawal. Number two, reduces cravings. And number three, gets them to a blocking dose so that the patient no longer has to use illicit opiates. Methadone is a long-acting opioid analog that has a highly variable half-life based on liver function. In the vast majority of patients, methadone's half-life is greater than 24 hours, so it accumulates in the liver, and the serum level will increase without any increases at all. Increasing methadone too quickly can lead to sedation and respiratory depression. The availability of carfentanil derivatives has changed the game a bit in the past few years. We used to expect folks to use a little heroin or pain pills on top of methadone until they achieved a stable dose. Now that's not as advisable. There is a greater challenge in getting them safely on a stable dose without causing harm from going too fast with the methadone increases. Just because someone tolerates a high dose of heroin, oxycodone, or hydrocodone does not mean that patient will have tolerance to methadone due to differences in metabolism. There is no expected conversion of doses. The maximum starting dose for new patients on methadone is 30 milligrams, although it can be more if it's a direct transfer from a hospital or another opioid treatment program that is well documented. You may want to start with a lower dose if, number one, they've never tried methadone before and their tolerance of methadone is unknown. Number two, they're not in significant withdrawal. Number three, they're using illicit drugs or prescriptions that can cause respiratory depression, like other opiates, benzos, or gabapentin. And number four, they have other medical comorbidities like COPD, sleep apnea, or cirrhosis. Remember, your local hospital can start buprenorphine, and our state-operated alcohol and drug abuse treatment centers, ADATCs, now have OTP licenses to start methadone or buprenorphine. So if you have a patient that you're concerned about starting in your OTP, you can refer them out to get started as an inpatient. Once you start with 30 milligrams of methadone or less, most North Carolina OTPs allow patients and nurses to use opioid withdrawal scales, like the COWS, to increase the dose 5 milligrams every 2 to 5 days until they get to a dose of, say, 40 to 80 milligrams. It is best for the medical provider to see the patient back as often as possible early in treatment, and if the nurse or patient has any concerns. In your induction order, you should allow patients and nurses the ability to lower the dose 5 milligrams or call the physician for an order if they felt any sedation the previous day, and not allow for further increases until the patient is reassessed by a medical provider. For reinstatements, recent admissions, or patients recently in another OTP, you may want to go faster to get them up to a known stable dose. For buprenorphine, most OTPs in North Carolina start with a test dose of 2 or 4 milligrams to see if the patient gets precipitated withdrawal, with repeated doses up to 8 milligrams on day 1, up to 12 milligrams on day 2, and a maximum of 16 milligrams on day 3. The induction order should be individualized. You can have a conservative protocol or standard as a guide, but each order should be made with the individual patient in mind. If you have further questions, please feel free to contact your SOTA. Thank you for watching, and keep up the good work.